Hey everyone, I want to welcome you all to the fourth and last part of our Bridging the Gap, Reducing Disparities in Diabetes Care virtual annual meeting. Our session today will focus on cross-sector perspectives of successful partnerships that support patients' unmet social needs. We have a great number of sessions over these last few months and really focused on a variety of wonderful topics. We heard some great work that's happening across the initiative on screening and referral activities across all the grantees. Hearing the sustainability efforts and just making the pitch for integrated medical and social care from Lori at Western Maryland. And we've gotten a great opportunity to dive into some really unique analyses regarding social needs navigation and what's happening at Roots Community Health Center. So it's been a really great few sessions here, and we're really looking to wrap this last one up around this really important topic. And so the resources available to patients support unmet social needs also depend on cross-sector collaboration and communication. So we have an opportunity here to learn from folks from a variety of perspectives and organizations. And I'm really excited to have these three wonderful organizations joining us today with extensive experience working in this sector. They'll provide their perspectives on how they navigate unique challenges and barriers when working with healthcare organizations to provide resources to support patients with unmet social needs. We have a wonderful slate for you planned, and so we'll do this quick introduction to the group, and then we'll jump right into the presentations as well. After each organization is presented, we'll have a general question and answer session for all the presenters, and then a short wrap up at the very end. I ask that you keep yourselves on mute during the presentations, but you are welcome to drop questions in the chat. Katie and I will monitor the chat for questions, and if we can either share them for you, or we can ask you, you can go ahead and raise your hand and ask the questions yourselves. And with that, I'd like to introduce Diana Marquez from Impact Northwest, who will share their experience working with Providence Health and Services, as well as other healthcare organizations in their community. And actually, they're going to start with a nice YouTube video that talks about a little bit about their program.
Impact Northwest is a multi-pronged social service agency. Our core mission is to prevent homelessness and keep people housed and stabilize them.
We literally have thousands of folks who are one missed paycheck away from losing their housing.
I think a lot of people in Portland are very aware that there is a housing crisis and very aware that we need to do more as a community to step up and help those around us who are working hard to stay in our neighborhoods, to stay in our communities, and who just need some help to do that.
The work that Impact Northwest as a whole is doing in our community is vital. There are a lot of gaps in the services that folks are able to receive, and Impact Northwest is there to help fill those gaps and to help our community achieve self-sufficiency.
Being able to get services from Impact Northwest is amazing. They're trying to help me be stable and maintain.
This organization is doing so much for our community members. We have lots of different departments working with children, veterans, recovery. There's so many different aspects of someone's life out in the community that we are providing help and assistance to.
We really believe that people need to have the stability of, okay, I know where I'm gonna go home to. I have a place for me and my family to live before they can look at any other piece of their life. That's a basic need.
Having a home has meant so much to me because growing up, I didn't have a home. Without Impact Northwest, I wouldn't be here.
When people come to us, they're already presenting with a ton of grit and diligence and hard work. We're really motivated to match that. We walk with them on their journey, no matter where that is, so they can fulfill the dreams that they have for themselves and their families.
Thank you for helping with that.
You're so welcome.
Okay, now let me tell you a little bit about our Community Resource Desk program that we have with Providence. We've had a partnership with Providence since 2014 when we first thought of a model where social service agency staff, which we call resource specialists, was stationed in healthcare facilities to connect visiting patients with social service available in their communities. Since then, we have learned a lot about collaboration between these two worlds To make it work, there are some necessary components that have to be in place, such the ability to adapt to the settings and follow both the medical institution policies and procedures, as well as of those of the agency. The need to be flexible is big, and to have in mind that building a program is constantly changing and evolving conversation. How a program starts out, it may not be the perfect model 10 or even 2 years from now. This has been seen during this epidemic. The CRD model has evolved from when it started to adapt to our current life situation. In general, the CRD was built for specialists to be incorporated into the medical institution setting and the way we use their internal system in communication via team and through the referrals and EPIC. This way, our specialists are more accessible to the medical providers. We have also learned through the years that social work and medical institutions have different pace. Social work is very fast to adapt to make programs work. Decisions must be made quickly, and that's not always possible in much bigger healthcare organizations. For example, we and our Providence partners, we knew from the beginning having one of the locations was not visible. But before it was possible to move the desk, it took a couple years to move the desk where we can be visible. Another barrier we had to overcome was related to staffing and HR policies. The specialists go by Impact Northwest personnel policies when it comes to most things. For example, when the agency decides to go remote, grant time off, or introduce a new holiday. However, policies for both the medical institution and the agency are taken into consideration when it comes to big decisions, such as expanding the services or adding other community partners to the program. Being able to combine and navigate the two when needed is an essential skill. I think it is important to say that all barriers or challenges are easier to be conquered when there is common vision and shared vision service philosophy. That definitely helped us in our partnership with Providence to always get things sorted out and process improved. Even though we do not have any examples of serious barriers or challenges to share with you from our work with Providence, generally speaking, one area where I see a lot of potential for the healthcare systems to exercise their immense influence is the way they budget for their partnerships with community-based organizations, especially in their decisions to pay living wages to our employees. We bring a lot of knowledge, life experience, and diversity to your spaces, and we believe that compensation for this work should be fair and equitable. It would also be great if the capital accumulated in the healthcare was being reinvented in the communities that needed and used for rental or basic needs assistance. In our work with Providence, we have seen so much success in individuals' people's lives. Like any partnership, this is an ongoing investment. The relationship is constantly evolving. Both sides put in the time and effort to build programs that work well. The key to making it work is open communication and transparency about all situations, taking all opinions into consideration and showing the work that is being done on a daily basis to make sure the model keeps working. And that is it.
Alrighty, thank you so much, Anna.
You're welcome.
Anything from Yana or Rachel you'd like to add? Otherwise, we can kind of move on to the next presentation.
I do not have anything else to add other than the partnership with Providence, the model that we started together, in my eyes, is like ideal model to work on and develop and improve, for the future. I really like the idea of merging social services and healthcare because they are so connected. And I echo, I apologize, my cat, of course, if I don't have kids jumping on my head, my cat will. But I would really like to echo what Diana said about reinvesting in the community. I would love to see healthcare systems building homelessness prevention programs. I'm speaking because I'm biased. I work for an agency that has a mission to prevent homelessness, so we see a real crisis in the streets of Portland. And it's a shame that, human life can shrink to what we're seeing in our streets. And it would be great if we could reinvest the money that are in healthcare in programs that could help improve that.
Yeah, especially into rental assistance, which is the lack of services that Portland has.
Yeah. Thank you.
Yeah, no,
Thank you.
that's so interesting too, because I've just been able to kind of see from afar this collaboration between Providence Health Services and the work that you guys have done. But to know that there's that need for reinvestment, and all the work that's happening in Oregon and the West Coast in trying to support these needs, there's still that need. So it's just important to know that reinvestment really needs to occur. So thank you. For that.
Thank you.
So we'll hold questions till the end, but I'll now hand it over to Amy Luckenbill and the Idaho Food Bank.
Thank you so much, Jake. Can you hear me okay? Awesome. I will go ahead and share my screen while I'm doing so. Hi, everybody. My name is Amy Luckenbill. I'm the Director of Community Initiatives here at the Idaho Food Bank. I am here with our CEO, Karen. Introduce yourself, Karen.
Thanks, Amy. Hi, I'm Karen Bauk, the President and CEO of the Idaho Food Bank, and really delighted to be here with you today.
Our Chief Development Officer, Morgan Wilson, is also here, as well as our Community Health Coordinator, Stephanie Medina. So you got the whole crew here today. We're so grateful to be here. Also, just making sure you can see my screen all right. Great. So just briefly, the Idaho Food Bank's mission is to help feed, educate, and advocate for Idaho's hungry through collaborative partnerships to develop efficient solutions that strengthen individuals, families, and communities. We accomplish this through our 3 distribution facilities located here in Boise Meridian, up north in Lewiston, in the northern part of Idaho, and in the eastern part of Idaho, Pocatello, and through our over 465 community partners and our various programs. In 2018, the Idaho Food Bank established our Hunger to Health strategy. It's based on 3 pillars, that is nutrition, education, and healthy communities. And this strategy really recognizes and focuses on the relationship between nutrition, food insecurity, and health outcomes. So the nutrition pillar recognizes and focuses on providing healthy food based on the USDA My Plate guidelines. And we follow our own nutrition philosophy. Education is a critical component. We deliver cooking and nutrition education so that people not only receive healthy food, but they get information about what those are and how to use them, how to store them, how to prep them. And we also distribute nutrition and community resource materials. So other community resources we distribute through our partner network, through our e-letter newsletter. Those are related to more social determinants of health and may include things like health insurance, housing resources, et cetera. And then the third pillar, healthy communities, really emphasizes and recognizes that collaboration and partnership with community and healthcare partners is so critical to address this role of food as a social determinant of health and promote that overall community well-being. So along those lines of partnership brings us here today. We started this incredible partnership with St. Mary's Health in Clearwater Valley. Cody Wilkinson is also here today. He's been an amazing partner to work with. So since 2019, we've been working together on various initiatives and partnerships. What that looks like is, first of all, co-location of services. So Cody's team and the St. Mary's Clearwater Valley team come on site to food pantries and mobile distributions that we have within communities. And they do things like distribute information on medical or social needs. They might perform health or other social determinants of health screenings, and then make referrals as needed. So those individuals who are already coming to the food pantry, who are experiencing that food insecurity and might need some additional help, are able to access these services and information while they're there on site, which, as we know, breaks down these barriers of access related to transportation, time, perhaps financial. Those visits started, the community health workers coming on site started in the summer of 2019 and continued as we were able to through COVID. Obviously, that kind of hindered our ability to do much in person, but we did what we could. I'll also note, the St. Mary's Clearwater Valley Health is located in that northern part of Idaho, so it's a very rural part of Idaho. And that's kind of an important aspect of recognizing part of the successes and challenges related to this partnership that we'll talk about a little bit later. The other thing that we did was we call them the Hunger to Health Forums. So the Idaho Food Bank, as you saw, has multiple partners spread throughout the state, and we support them and encourage them to engage in conversation about why is food important to health, how does it impact health outcomes, and what else can we do? And so Cody and his team and our partners, we brought them all together to have these conversations together as a network in partnership to talk about what else can we be doing together to connect health and food and those resources in the community. So that's been really critical to get our partners educated, excited, encouraged, supported to take part in some of these initiatives. It is something that some folks might see as going above and beyond just providing food. And so that support and conversation has been really critical and exciting to see even our pantry partners who may sometimes be run by volunteers get excited to engage in the work. Lastly, St. Mary's Health in Clearwater Valley refer patients who are food insecure. They do a food insecurity screening on site, and they, with the awareness of what pantries and food resources and distribution sites are available in the community, we'll make that referral. So kind of closing the loop there. Necessary components of the success of a successful partnership. Firstly, it's those dedicated resources. So staff, time, funding. We have to have the people and the money and the time to be able to build these relationships and coordinate those efforts. So my position is very much dedicated to this. Stephanie, our community health coordinator, is dedicated to simply reaching out, developing relationships, and coordinating efforts. We also have the incredible support and promotion from our executive leadership and board of directors, obviously without which we would not be able to kind of move forward in this work either. And in Idaho overall, there is a conversation at the statewide level about care transformation partnerships and this recognition of social determinants of health being this really important part of health outcomes. So I think at a statewide level, the conversation is happening, which also just helps support when we do reach out to another healthcare provider or our pantry partners. It's not a surprise, or there's already some baseline understanding or awareness of it, which has been helpful. And then, really, really critical has been learning from and responding to the needs of individuals in the community. Every individual is different, every community is different. And unless we're really listening to what that community needs, we're not going to be successful in delivering and meeting the needs of that community. So I'd say related to that, a unique challenge is every partnership is different and every community is different. So there's no one size fits all. It's really important to have those resources, have those conversations, take the time to understand what the need is, and then come in and figure out how can you best meet that. Again, with the rural nature of some of these locations, every community has their own culture, and we need to respect and honor what that is. A unique challenge or barrier is also this commitment from both the healthcare partner side and the community partner side. So as I referenced, the Idaho Food Bank has this network of partners that works within their communities. And some of our pantry partners are larger organizations with more resources. Some are very small and they're volunteer led. And so these individuals who are volunteers might not have the time, the capacity, the information, the knowledge, the resources to take on additional initiatives. So getting the commitment from both sides is something that's important for success. Another thing to recognize is that community trust is really, really important. We can roll in with some incredible healthcare providers. Our community partner might say, yeah, come on in, let's do some screenings, let's do some healthcare, let's provide resources. But if the community trust isn't there to actually utilize that resource, then it's gonna fail. And we've actually seen that before, where it'll take some time for a community to build trust in a resource. And I'd say St. Mary's Health Clearwater Valley does have that community trust. They have a presence and an awareness and a knowledge of and a relationship with the community. So that's been really, really important, and something that we've learned moving forward too. It takes time to build that trust. Sustainability of programs. I heard Impact Northwest kind of mention this as far as the investment of resources. So Connected is funding and reliance on grants. As a nonprofit, we're often reliant on what funding is available. And sometimes grants might be outcomes focused, or there might be certain limitations or restrictions based on grants. And so we're having to focus our activities based on what is available through that funding. And then obviously, I'm preaching to the choir here about today's challenges. Healthcare capacity is strapped. People have the desire and willingness and want to co-locate, to collaborate, to develop new initiatives and programs, but they don't have the capacity or the bandwidth because their teams and their staff are they're spread thin, and they're focused on what they're needing to do to respond to the current COVID pandemic. Moving forward, the Idaho Food Bank is very excited and sees the potential and value in continuing to build healthcare relationships. So we're continuing to connect with healthcare organizations and our pantry to strengthen and provide those co-location of services and that referral process. We recognize that community health workers are a really based resource that can increase that referral and follow-up. We know that referrals are as effective as when they're actually made, and recognizing what follow-up occurred or being able to address barriers with follow-up is really important. So we recognize and appreciate community health workers as an important partner moving forward. We have dedicated staff, myself and community liaisons within communities to develop those relationships and trust. And we're excited to look at and adopt some new technology that'll help us, such as findhelp.org, being a platform that's being adopted in Idaho to help with those referrals. Hopefully I didn't scream through that too quickly. I appreciate everybody's time. There's my contact information.
Thank you so much, Amy. I was lucky enough to sit down with Amy and Karen and Cody for about an hour in preparation for this presentation, and just kind of heard some wonderful things happening. But I want to kind of tap into one thing you mentioned, this Hunger to Health initiative, and how you kind of started with St. Mary's a little bit, but then kind of other hospitals kind of got hearing, correct?
Yeah, St. Mary's is definitely one of our, I would say, favorite partners. But yeah, we've expanded to some of the other community health centers throughout Idaho that have been great partners, as well as some of the larger health systems down here in the Southwest. So yeah, absolutely. We've been expanding that reach into all communities throughout Idaho.
Alrighty. Well, again, we'll do questions at the end. So I'll go ahead and move over to Megan. Megan, I'll get your presentation ready here just 1 second.
Thank you, Jake. Good morning, everybody. My name is Megan Nieto. I am one of the co-founders of CHW Solutions. I am also a certificate holding CHW here in Minnesota. All right, next slide. So just a quick slide about CHW Solutions. We started our business in 2016. The other co-owner, co-founder, her name is also Megan Ellingson. We are based in St. Paul, Minnesota. We do have a statewide service area. We've also been doing some national projects, which is exciting for us. And we are dedicated to developing sustainable models for community health worker services. In Minnesota, there is Medicaid reimbursement for patients that are on Minnesota Medicaid, and that also includes dual eligible individuals, so Minnesota Medicaid and federal Medicare. So we have the reimbursement that has been in on the books at DHS since 2009, but there were very few organizations that were actually submitting claims for said services. So we saw that gap, and our past history of working in public health and community-based organizations included developing models for lead screenings and healthy homes and in-home visiting. So we were like, right, this was just totally like our game. And so we started it to fill the gap. And then we do have a medical director, and we have a couple of backup medical directors that are physicians. We have an evaluator on our team, and all of our community health workers right now are contracted employees. Okay. So here's our pictures and a little bit about Megan and myself, just some quick bio information. Okay, next slide.
Next slide, Megan.
Yes, please.
Oh, sorry.
Oops, that's okay. All right. So we, CHW Solutions, we are our own business. We receive referrals from 5 Minneapolis FQHC clinics, and they are the clinics that are involved in Merck. So CHW Solutions, our community health workers, for the most part, are outside of the clinic walls and doing in-home visits with patients. During the pandemic, we have been doing telehealth for the most part, except there's always a handful of patients that are hard to serve over the phone for CHW services. So we've been easing back into visits now a little bit here towards the tail end of the pandemic. So some of the things are important components, communication, clear, concise communication with clinic partners. We have developed an awesome relationship with Southside Clinic that includes weekly standing meetings where they're sending us referrals, and then in the standing meetings, we're running the patient lists. It's an opportunity for CHW Solutions for us to gather updated clinical information and develop a plan for non-responsive patients. Pilar, the RN at Southside, she is really the kingpin of all things Merck, all things diabetes for that matter at Southside. And so when she is doing patient visits and she's talking with patients, she is including community health workers. There's most of the patients coming from Southside are Spanish speaking. So it's myself and Hilda, another CHW that speaks Spanish. So she's including us by name. She's giving the patients our phone number. She's talking with the patients really intentionally about who the team members are that are going to be contacting them. And throughout the course of the last 4 years of Merck, we have really cut down on non-responsive patients. And I truly believe that it's because Pilar is setting it up from the beginning. So she's taking those in-clinic visits and kind of setting up how things are going to work for Merck. The frequency for us weekly has been great. It's actually been kind of our gold standard now for about 1.5 years. It's enough time getting an hour on our calendars, and we have enough time to talk about new referrals, to talk about current referrals. What we found is when we had more time in between, we had to spend time remembering what we did the previous meeting. And then if we have an hour set aside, if we don't need it, well, we just give everyone some time back in their day. I don't think anyone's going to be sad about that, right? And then getting the meetings on our calendars, like we all are taxed, our plates are overflowing. So getting the meetings on the calendars so that we're not trying to do doodle polls and, every week and trying to figure stuff out. So that has worked really well for us. Again, having access to that internal clinical staff or patient information has been key for us to set up our referrals and set up our messaging when we contact patients. So just some things about referrals, consistency of patient information. We're able to get clinical notes from Southside. That has worked super well. We're able to kind of tee up our health education information on that first phone call based on the clinical notes. We get updated labs, so we're getting updated A1Cs on the regular. That is extremely helpful. Consistency of format, so paper forms or electronic templates, but making sure that from all of the referral sources, the paper forms or electronic templates look the same. And then the consistency of the receiving method. This is something that we're still working on. Either, whatever, secure fax, a secure email, or a web-based platform, having one spot where all referrals are coming in. The pandemic kind of threw a wrench into that. So some were coming by secure fax, others were coming by secure email, some were still coming through a web-based platform, and it's very, very easy to lose track of things if you have multiple referral sources that are flowing into your agency, but they're not coming in a consistent format. So we've really tried to migrate to secure fax using one form. I know we're a little bit OG, we're still using paper, but we've really tried hard to migrate and have it make so that it looks the same. So if I'm looking at referrals today and Megan's looking at referrals next week, and somebody else might be doing it, well, maybe we're on vacation or out of the office or in a meeting or whatever the case may be, they know exactly what they're looking for. An internal champion invested in the project, and then understanding a common understanding about CHW roles. Okay, next slide. Oh. All right, so as I mentioned before, Minnesota does have reimbursement for patients that are on Minnesota Medicaid. There are rules around CHW service delivery, health education, patient self-management skill building, and community resource connection. Those are the three pieces that need to be braided into every visit. So if we get referrals just for housing or just for transportation or just for food or just for support system, in order for us to submit claims and receive reimbursement and be in compliance with DHS, we have to be braiding in health education and patient self-management skill building. So that is one of the reasons why the clinical note and this deep connection with clinics to know what's going on medically with the patient and how can we help support the patient with health education. So we'll sometimes get referrals. They'll say, a provider might say to us, I've done education about carbs and cholesterol, and the patient is still not understanding. Could you please do more education about those two items and what they are and how they're different? You got it. Sure thing. So getting that information is very helpful. Again, there's compliance rules that play into when FQHCs have CHWs, which is one of the reasons that CHW Solutions is providing CHW services. It's all about billing and how it's different within clinic walls at FQHC clinics. So one of the things that we have done here in year 5 is we've had discussions with DHS about how can we have our community health worker, an employee of CHW Solutions, be actually sitting within clinic walls and serving patients within the walls of the clinic, meeting with providers, being pulled into clinical visits at the tail end of the clinic so that the patients know who she is, they can see her face, she's as introduced as part of the team. So we've had these really great discussions with Department of Human Services, and those discussions have been very fruitful. We have figured out a way that we can have her in there delivering services under our standing order, and we can still submit claims for our services. And that all started with a phone call to DHS and an email and hey, here's what we want to do. And we need your help to be able to figure how this is going to work. And now she's about a month and a half into being in the clinic a couple times a week, and it's working perfect. So one other thing that has really helped us out is that was my 10-minute timer. Is common language within systems. What do CHWs do? What is their role? What activities will they be doing? And how can community health workers and others, providers and staff, complement each other? How can we work together? I will be your extension outside of the clinic. Let's partner to make sure that all of the messages are consistent and we're all working together as a team. This piece has been really, really important, just not only for Merck, in general with community health workers, there can be some territorial, weirdness. Totally doesn't need to be, but it's just a lack of understanding about what community health workers do. So making sure that common language is there is something that's super important. Thank you.
Thank you so much, Megan. And no worries, it's okay to go a little over. That was some great info to share with everybody. And so I'm actually just going to kind of welcome all the presenters back to answer questions. Folks are welcome to send questions in the chat, but I'm actually going to just be the first one to ask a question because I've kind of heard a consistent thread from the three presentations as it relates to just having ready access to data and information. It was kind of talked about in different ways. I thought that, Megan, you talked about the specifics of just really needing to have that patient information to even create that relationship. Diana, I thought you talked really importantly about just kind of the need for that connection, or just kind of how Epic is utilized between your organization and with Providence to help that communication. And I know that the Idaho Food Bank was talking about the importance of screening and how those results get over, how those results are utilized. So I kind of want to ask a question to all three of you, and you can kind of answer it however you want, but how important is this issue of having ready access to medical information, clinical information that has classically stayed only in the medical sector?
Yeah, the access to that information for us literally makes or breaks our first encounter on the phone with the patient. If we don't have enough information, we sound super spammy, right? Salesy, spammy. We don't sound like we're part of the team. I've received referrals before where I legit don't have a last name of a patient. Like, hello, Jake. I'm not sure what your last name is. I mean, I'm not confident when I call a patient if I don't have enough information. Also helps me to take, 2 minutes just to prep myself so that I can see where we're starting the conversation, right? And I can see things that the providers have said to the patients. I can mimic that same language. So it sets me up to be part of the team. My confidence level is boosted. I don't sound spammy or salesy or, like calling about your car warranty and all of that, right? Like, I don't want to be that person. I want to be part of the team. And so having that clinical data and being in that information and be able to use that and getting consistent data, it sets us up for a much better relationship with the patient.
All of that. Plus, not only it sets us up for better relationships, it also sets us up for better results. So prior to having access to referrals from Epic, our success rate was just not in connections, was just not so good. So that kind of allowing Epic to be able to send us referrals allowed us to increase the numbers of people that we were able to reach out to. And yes, I mean, having access to all the information and, connection data, it was just a deal breaker for us. Thank you.
Thank you.
I'd say that's a really good question, Jake. From the Idaho Food Bank and partner standpoint, I think we're not there now, but an ideal future world would look like a patient, is screens positive for food insecurity, gets a recommendation or a referral for a resource within their community. And then there is a warm handoff from an individual to say, okay, now here's a food pantry, here's a mobile distribution where you can go to. And then on our side, we know who that person is and what they might need. And so we can direct them to maybe specific types of food that would meet their individual need, if they're a diabetic, or if they have high blood pressure, or if they're gluten-free or vegetarian, or if they have certain religious preferences. Then they experience this honor and dignity on the food pantry side. And it's because we have that information to be able to guide them in that way. We're not there yet, again, but gosh, wouldn't that be an incredible, dignified, respectful experience?
Mhm.
And
If I could jump on that to build on Amy's response, because that's a perfect description of what we'd like to see going forward. But I think this is also a challenge for nonprofits like the Idaho Food Bank, because we're not HIPAA certified. We don't have everything in place to meet all of those kinds of controls. And it would be a heavy lift for us to think about doing something like that. So having the partner like Cody's organization handle that part of the relationship has been really important for us, because that's not our burden. They're able to manage that kind of information.
Thank you all so much. That was great. Marshall, I have a great question. Do you want to ask it, or should I ask it for you?
Yeah, it's just great talks, everyone. Just sort of wondering that, you guys are like innovators that are at the forefront, and so are competitive for these individual grants. But you're the innovators, so the most competitive people for these grants. And so if we're thinking about more sustainable funding streams, both for yourselves as well as groups that may not be as advanced at ESU, that may not be successful in getting individual grants. Any suggestions, if you were the all-powerful czars regarding ways to create sustainable funding streams, whether they're from healthcare sources or social service sources or both? What comes to mind of if you could wave the magic wand of ways that you think might be possible?
Marshall, that's a very complicated question. I don't know how to answer that. I think that in order to find sustainable funding for these services, the whole philosophy that this country was built on would have to change. And I'm speaking as an immigrant, as an outsider who has experienced, growing up in socialism and now lives in full-blown capitalism. And so I can see advantages and disadvantages of both of the systems. And I kind of hinted on that previously. Human life just has to have a bigger value. It just breaks my heart seeing the poverty levels that are in the most advanced country in the world. You don't see that anywhere else. This is just sad. We not in resource navigation programs, but I work in housing, and we've seen an influx of money pouring in for homelessness prevention. And this is the first time ever, and I've worked here for 10 years, that we have enough money to cover the need that we are seeing. But it comes with a lot of conditions, such as, we're not paying living wages. We're not getting the indirect rate that we need to keep our agency afloat. All of those things are kind of connected back to individualism versus collectivism. And can we find a middle ground? I don't know. But in my opinion, the middle ground is the way we have to go in order to succeed.
That's a great answer. Yeah, wonderful perspectives, the big picture and the philosophy underlying. How about the other sites? Any thoughts come from your context?
So when I think about this, and I think about the organizations that I've worked with in the past, and some of the organizations delivering CHW services in Minnesota, they are not healthcare organizations or organizations that know how to submit claims. However, they are organizations that have people that create wonderful relationships. And a lot of the way that our company has been able to get contracts, become providers with health plans and the payers has been through relationship building. It is not quick. It's not going to happen tomorrow, but those relationships and setting up those relationships to be super solid, it's all about personalities, right? It's all about finding people within the organizations that you vibe with and people within the organizations, the healthcare payers that are interested in boots on the ground service that are going to reduce disparities and help with their bottom line. It's a long process, right? So there's contracting, then there's value-based, the kind of value-based projects. The thing of it is though, is it's all about personalities and figuring out kind of before you enter into these relationships, like what can we offer them? They're going to want metrics. What can we offer them? And we all know keeping data, whoa, right? It can be immensely intimidating. But figuring out ways that your community health workers and your programs are helping their bottom line. So let's start building the relationships to be able to be reimbursed and have sustainable funding streams. When you get into submitting claims, it can be kind of scary. But the reality is health plans have a lot of discretion about CPT codes that they use. I mean, everyone has to be able to submit a claim, but that really isn't that hard. Submitting the claim isn't that hard. It's getting the relationship built so you have the contract or the value-based contract or the provider contract to be able to submit those claims. So if you have an inkling in your organizations that, yeah, we might want to try and dabble in that a little bit, my recommendation would be start those relationships. They probably, people from the payers probably sit on committees. They are, operating within your circles, finding that person, going out for coffee, having Zoom coffee, and starting those relationships. That has helped us tremendously to be providers and to get provider contracts. And our company doesn't look like a typical healthcare company, but we have contracts and it's all about relationships.
I'm gonna say that's a really, it's hard to follow because I agree, agree with what Megan said. And Karen, feel free to jump in here if you have thoughts.
Yeah, exactly. I was going to say, Megan, well said. That's you captured so many critical points in that. It seems like it's this convergence between the relationships, whether it's with CMS or with the payers, and understanding there's a common objective here. The amount of money that we're spending right now in our country to fix problems that are preventable. I think everybody knows that, right? It's trying to figure out how do we turn that around? How do we start to spend differently with different kinds of services? That is the big challenge. And examples like we're hearing about today are definitely helpful. You start to gather that research and the information that proves this is where we can make a difference. But I also think this is a long-term game. We got to be in it and stay diligent in showing these kinds of results and helping those who make those funding decisions recognize there are viable options to make these changes and do it differently.
I'll just tag in with I agree. It's a long-term solution. In the short term, the Food Bank has been really, I think, grateful to have some trusted relationships with a couple of larger organizations, a larger healthcare entity in Southwest, and then a larger business who have given us some grants that are longer term scope, as in a few years, and less restrictive. And so that allows us to not be held. So it's less restrictive. It allows us to kind of explore, learn, adjust, and evolve, as we know that's needed for some of this work. So organize that back to the relationships. You have a relationship with an entity who is willing to invest and has some trust in your organization, and you're not held so much to those specific metrics. We've experienced you can get a little creative and accomplish a lot more, actually.
Yeah, I would echo what my colleagues said, particularly about the importance of relationships, but also add that I think it's important to, even if you can't get everything done in one fell swoop, to start making incremental change and starting small pilots. So in Trenton, we were lucky enough to partner with one of the larger footprint managed care organizations operating with lives insured in town, as well as the state Medicaid. So in a couple of different streams. So our designation as a regional health hub in New Jersey gets us access to a little bit of funding that we have dedicated towards care management and CHW services. Not very much in context, but it's something, and we'll be able to start showing our incremental value to them. And I'm sorry to use the language of capitalism, but that's what everybody wants to hear. I agree ultimately with Yana that we need to have a fundamental change, but we're certainly not there in the next couple of years. But the importance of sort of painting the ROI picture and guiding them to that decision, I think is pivotal, and we need to do that in small steps. Like we started with a very small but multi-year pilot that's since grown considerably to embrace managed Medicaid lives in that pilot. And Cheryl, who's on the call today, and her team are doing great work there. But ultimately, what's going to come out is an analysis of the ROI for that insurance company. And we do our best to give the best care possible, but ultimately we're going to be judged by what we're able to create with their investment. But we have to start small, and I think that's the key.
These are such helpful comments. Katie and I were talking this morning, and we're almost at time. But Katie, do you want to get on a soapbox for a moment?
My soapbox is that I want another metric besides ROI. Just because we've had so many years of underinvestment in public health, underinvestment in social service sector, and underinvestment in primary care, which just holds so much opportunity for health, wellness, and disease management. So yeah, I just appreciate you all and your work, and I'd love for ROI to shift and for it not to be like our guiding light at some point.
I want to thank Diana, Yana, Megan, Karen, Amy, and your teams for just wonderful presentations. I think this was such a wonderful, wonderful presentation to kind of hear just a lot of different perspectives and angles. Something that Rachel just kind of highlighted in our chat regarding some HIPAA requirements and kind of working on that with Impact Northwest. But I just like her last statement is that we absolutely require advocacy and development on the healthcare side to make some of the health information sharing possible. I'll just cut off the health information sharing possible. We just need more of that advocacy and development from the healthcare side. We need that collaboration, and we're getting there. I think we have 8 wonderful grantees and 12 wonderful sites that are doing exactly that. But I just want to thank all the presenters for taking the time out of their day to share their perspective, their opinions, and some great work that's happening.
Thank you, everyone.
Thank you. Thanks for bringing us together.
Thank you so much. Bye.
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 A wonderful day, everybody.
Thanks.